Hello everyone. Now I'll discuss question of neurology. So we have a 65-year-old man and he is brought to the emergency after having a seizures. She is a known case of non-small cell lung cancer. And MRI of the brain shows solitary cortical mass 2 centimeter by 3.5 centimeter. Well, that is most consistent with metastasis because this is in the junction, gray and white matter junction. This is a very, very important point, and this is very consistent with metastasis. Okay. Well, CT chest abdomen shows no evidence of recurrence. Now, what is the most appropriate next step in the management of this patient? Well, the answer to this question is surgical resection of the mass. Why this? Why not others? Let's discuss. Now, metastatic brain tumor are the most common type of intracranial brain tumors in the adults. But here I like to add something. But in the children, it's a primary brain cancer are much more than the secondaries. This is the very, very important point that you got to remember. Well, when we talk about this metastatic brain tumors, they can be solitary or it can be multiple also. And they are usually seen in the gray-white matter junction, which is there in our question also. This is something unique about metastatic cancers. Well, metastases are frequently seen in patients with non-small cell lung cancer, like our patient in the question. He is a known case of non-small cell lung cancer, and we are seeing that in the brain MRI, they are there in the junction of gray and white matter. Now, what are the favorable outcomes after diagnosis? Age below 65 years. Good functional performance, stable intracranial disease, like in our patient is fairly well. Now, aggressive treatment is typically indicated for the better control for survival. Okay. Now, surgical therapy is the best in which situation? Single brain metastasis, like in our case, is a single metastasis there. It is accessible location, good performance status, and of course, once surgical has been done, like in our case, surgery will be done. Now, is it enough? No. Patient should be followed up for stereotactic radiosurgery, so-called SRS, whole brain radiation therapy, WBRT, okay, to the tumor bed. They are additional things that we have to do for the follow-up after surgery. Well, now SRS may be used in the alternative therapy in those patients who are not candidate for surgery, where patient is not fit for surgery due to other medical reasons. The patient having surgical inaccessible lesion or very small size tumor, then in such cases, we do not go for surgery, then we go for SRS. And similarly, patient with multiple brain metastasis or poor performance, WRT or supportive care therapy is also recommended. Okay. Now, option A, brachytherapy. Now, first of all, let's understand what the meaning of brachytherapy. It typically involves implantation of radioactive source directly into the intracerebral mass or in the surgical cavity. So we directly put the radioactive source into the tumor, and that will induce radiation, and that is going to cure the disease. That is brachytherapy. This allows higher radiation dose to be delivered directly into the brain without affecting other organ. Like this, the tumor mass is there, and in the tumor mass they have put this source of brachytherapy. So this will be directly affecting the tumor mass. It will not affect nearby structure. So because if you give radiation from outside, suppose this is the brain, total brain, if you give radiation from outside, that means whole brain is also getting affected. But in brachytherapy, localized maximum dose where we need, that will be affected. Okay. Well, it is typically used in conjunction with surgery or after recurrence followed WBRT or surgery. Okay. Well, combination chemotherapy. It may be used in cases brain metastasis from chemosensitive tumors like small cell lung cancer. We are well aware that small cell lung cancer are highly chemosensitive, lymphomas, choriocarcinomas. If we are getting secondary from these, then chemotherapy can be thought of. However, it is not benefited from secondaries from non-small cell cancer, or non-small cell cancer itself is not sensitive to chemotherapy. Now, I have a question for you. Stop the video, write down the answer. Which drug we use in the treatment of primary brain cancers? Write down the answer in your copy. Well, the name of the drugs are carmustine, lomustine. Well, I have one more question for you. Stop the video, write down the answer. What is the unique side effect which these drugs have? Unique side effect means, well, nausea, vomiting, etc. That can be seen in many patients with many chemotherapies. But something unique side effect of this drug. Write down the answer in your copy. Well, the answer is delayed bone marrow suppression. That means you are starting chemotherapy today, and the bone marrow depression will occur after somewhere around 5 to 7 weeks. So delayed bone marrow suppression is the unique side effect of these two drugs. Well, we look into the other option, palliative pain therapy and seizure prophylaxis. Okay, the patient has good performance status and there is no evidence of extracranial masses. It should be treated aggressively to improve survival. The median survival time for patients who receive supportive care and are treated only with steroid is just 1 to 2 months, which is nothing. And moreover, our patient is a solitary mass which we can accessible, then we should go for surgery. They are just supportive therapy that can be given, but that they are not the main treatment in this case. Golden line to remember, surgical resection is recommended for solitary brain metastasis in patients with good performance status and stable extracranial disease. In patients with multiple brain metastasis, whole brain radiation therapy is typically used. Thank you very much.